Another episode of BAEP Talks with. I am your host, Jasmine Evelyn, the president of the Barbados Association of Endometriosis and P.C.O.S. And today we're talking to an emergency department resident, Dr. Shayna Parris, about endo in the ER. So thanks for joining us, Shayna.
Hi, thank you so much for having me. It's my absolute pleasure to be here.
Thank you. So we are just going to read a little bit about you so our viewers know who you are. So I'm just going to read a little bit about you, Shayna, so that our viewers know who you are. So Dr. Shayna Parris is a senior emergency room resident in her final year of specialization in emergency medicine. She obtained her undergraduate degree, Bachelor of Surgery and Medicine at the UWI Mona, where she graduated with honors in 2013. She is passionate about women's and mental health, as well as enjoying the sea, sand, and sun, which is perfect because I love those things as well. So Shayna, tell us a little bit about you otherwise. Who is Dr. Shayna Parris?
Well, you would have read I've been a doctor for almost 10 years. Some days it feels like it was just yesterday that I graduated, and others it feels like it's been about 50 because of the high stress nature of the job. But I will say that there is never a day that I have really stopped loving my job, because it allows me to come into contact with people. And I think anybody who works with people, that is the real joy of their job, is getting to meet people from just right off of the street to people who work at all levels of society. And, you know, well, working in the emergency room, we actually see people on the worst day of their lives, unfortunately. But sometimes the beauty of it as well is that we see them on the worst day of their life. Sometimes we see them actually kind of looking into the light and at the pearly gates. And then I get to see them in the supermarket, and I get beer hugs in the supermarket, and there is no price that you can put on that. And so I think that is why I do what I do. Outside of medicine though, because you can't just be your job. I refuse to be defined so by my career. I enjoy the quieter things in life. I tend to be a bit of an introvert. So you will often find me at home, hoping that the rain will fall, with my nose just buried in a good book, or painting or writing. Those things tend to fill my cup, as well as being at the beach, as you would well know. So, you know, it's perfect that I live in paradise, really.
So I guess you kind of told us a little bit about, why emergency medicine is unique. I didn't think about the fact that you actually do see people at some of their lowest moments. And, then you go on to see them, as you said, in the supermarket, you go on to see them when they've pulled through, which I know is not something that's always the case. But I always think of emergency medicine as very, high stress. And like, what drew you to that? What drew you to emergency medicine?
I think it might even be the high stress. People tend to call us emergency medicine physicians as adrenaline junkies or idiots, quite frankly. And there may be some truth to both statements, really, because you never know what is going to come through the door on any given day. And that is actually, it's a double-edged sword, but that is the beauty of it. I might see a 2-year-old in one room, and then go to see a 98-year-old in another. And I might deliver a baby in one room, and then I might go to see somebody with a heart attack in another. My brain, is never allowed to get bored. I am always kept on my feet, literally and figuratively. And so it is a beautiful specialty, because we really are allowed to see the variety and the spice of life, and we really do save lives in the emergency room, and that is not to be arrogant, but it really is a privilege that people give us. They actually put their lives into our hands, and so that is why I enjoy doing what I do, despite the hard parts of it, meaning that we often face ugly things like death or disfiguring injury, or seeing people, you know, in extreme and intractable pain, or witnessing the real social ills of society. You know, we often see very, you know, homeless patients or people who've been abandoned. And, you know, you are human first before you are a doctor or before you are anything else in life. You are a human. And so you have heartstrings that get pulled at, and you have to learn to compose yourself in the face of that. But um, we you know, we try every day to do our best by everyone who enters through the doors of the emergency room, really.
Got you. And then, so I know there are other specialties in medicine, but how would
Mhm.
you like, which you've kind of done already, but how would you kind of like define emergency medicine? What sets it apart from all the other specialties?
So what our specialty really um, is a combination of all of those other beautiful specialties. We are in our training, we are required to return to each of them to learn from them so that we can do the best job that we do, right? Because we see geriatrics, pediatrics, gynecology, obstetrics, internal medicine, general surgery, or any other type of surgery, we have to return to those specialties first and then come back to our home in the ED. Um, so what we do is that when patients are unstable, meaning that their blood pressures are really low, you know, they are not behaving themselves, um, we are the ones who stabilize them, and bring them back and get that blood pressure back to normal, so that the specialist can then come in and do their specialist work as well. So our specialty is in the stabilization and in that acute phase of management when things are really haywire with the body and the stresses of the body, when people come in with trauma and accidents. We are the ones who coordinate that effort between sometimes many specialties, because someone might come in with injury to the head, the neck, the chest, the pelvis, the long bones, right? And that might require neurosurgery, ear, nose, and throat, cardiothoracic surgery, general surgery, and orthopedics. But we have to kind of steer the boat first and get things together for that patient so that they can actually survive all of those things that they're about to go through. Because if you make mistakes in those first minutes or that first hour, we kind of call it the golden hour, you may lose the patient. So that is our specialty, is is capturing people in the acute phase and in the emergent phase of illness, and stabilizing them.
And that's pretty special. I don't think I've ever thought of it like that. You're almost preparing them then to move on to the next phase and making sure
Yeah,
they can move on to the next phase.
exactly. And so people often forget that it is a specialty in itself. And there's this term that people sometimes use, and it's an old British term that we're referred to as casualty officers. But we are not casualty officers. We are a special type of physician, and we are emergency physicians, just like any other specialty is a specialty, because we train for 4 years after our initial degree in order to be able to practice what we do. So it very much is a medical specialty, just like anything else.
So Shayna, as you know, we are talking about, yeah, we're talking to about emergency medicine, but we also want to know for sure if you, like, you know, do you see any endometriosis or polycystic ovarian syndrome patients coming into the emergency room? And if so, like, how often do you see them?
For sure, we do. Um, Perhaps not as often as other conditions. Like we may see strokes and heart attacks every day, but we may not see someone with PCOS every day, typically because PCOS tends to be a disease that largely doesn't have many emergencies, thankfully, associated with it, and can be managed on an outpatient basis. We do see patients with endometriosis, though, however, fairly commonly, because it's such a painful condition, and sometimes you cannot manage the pain at home, and when pain is extremely severe, you really should present to an emergency room, because you don't know if something acute and very dangerous is happening inside the body. Pain is the body's signal to the brain that something is wrong. So we do see our endometriosis patients quite frequently. So some of them we do know, because it is just the nature of the disease. So we are familiar with it. Just like how we do see from time to time patients with sickle cell disease, because that is another very, very painful condition. And they, unfortunately, sometimes you try to take painkillers at home, you try your best, and you have to come to the emergency department sometimes.
Yeah, and just to make it clear, so if pain is unbearable, and if you are experiencing excruciating, debilitating pain, you should head down to the emergency department.
By all means, yes, because none of us, not even me, have bionic vision. And sometimes, yes, we know endometriosis is, and we will talk about this a little bit more as we go into discussion about what endometriosis is, and why it's so painful. So we know by its nature that it's a painful thing, but you can't just write it off as your at every pain as your endo pain. You can get dangerous things happening to you, like an appendix rupturing or an ovary rupturing, and lots of blood can accumulate in the abdomen in that way, and you will have severe pain. And if you stay at home, you run the risk of making yourself extremely, extremely ill. So anytime when pain is very, very severe, it is a red flag that something is wrong. Right, and you should have an evaluation by a physician. Yeah.
Good. So, okay, let's say my pain is debilitating, and I'm a person. Let's say I'm a person with endo, and I come down to the emergency room, emergency department. What should I expect? Like, what is gonna happen? Because sometimes you go there and you think that you're gonna go in and you're gonna be seen. Like, tell us what happens so we can understand the process and the protocols that happen in the department.
Sure. I mean, and I think if you don't understand the process, then that is what gives rise to the frustration, as well as the fact that you are, as we just discussed, you're in pain. But unfortunately, the emergency department serves every population that there is. And so that means that we never know at any which moment what will come through a door. And so it means that the ambulance might come through the door with a heart attack, a stroke, somebody who they're already doing CPR on. And sometimes, unfortunately, there are like 3 doctors on duty, and 3, 4, 5 ambulances turn up at once, and all of them having very ill patients. And you wish that you could be an octopus in that given moment. And so when very, very ill patients arrive to the emergency department, it almost arrests what happens in that for a few minutes, because all of the medical professionals have to attend to that patient. And if you put the shoe on the other foot, if it was you, your mother, your grandmother, your brother, your wife, who was having a heart attack or who was having CPR, who had drowned, you would want every single person to give that person their attention at that moment, honestly. None of us would want that, to find out that our relative died because there was only one doctor available and they could not do everything. All right. So that is one thing. So what that leads to is that we need to undergo a process called triage.
Yes.
And what triage means is that we decide, based on the severity of your symptoms and signs, meaning your symptoms are what you complain of when you come, meaning like if you are having a tummy ache, or if you are having neck pain, if you are vomiting, having diarrhea, if your eye is hurting you, and how severe those things are. Your signs would have been like the vital signs that the nurse takes when she first sees you, right? So like your temperature, blood pressure, heart rate, your oxygen levels, things like that, right? And we use those things together to make a decision about how soon you should be seen. So it so happens that often there are many people who are very ill and require urgent to immediate treatment. And we are just all trying to juggle that kind of thing 24 hours a day in the emergency department. And that is something that I often watch the experiences of my colleagues internationally, in America and in Europe, and in other EDs, and the experience is universal. What they say sounds exactly like the words that are coming out of my mouth, except that they are in a different location geographically. Our emergency departments are just always overwhelmed. It's just something that is very difficult to deal with. So it doesn't make anyone's pain or condition any less valid or important to us. But it just means that we are trying our best to get to the sickest person.
That's a priority.
Yeah.
It's not a first come, first serve.
Right. So after we have triage based on the severity of illness, then we go by order of time. Because of course you would understand that you don't want to be sitting in the waiting room and realize that you have come at 2 a.m. and the person who came at 10 a.m., both of you are, equally fairly stable. You're stable enough to be, in the outer waiting area of our ED, and the person who came 8 hours after you just waltzes inside.
Basically what you're saying then, Dr. Parris, is that when you present to the A&E, it's not necessarily, it's not on a first come, first serve basis then, that's what you're saying?
No, it is a combination of things that we use to determine the order in which you're seen. So yes, the time that you presented to A&E is taken into account.
Right.
It's taken and documented on every single note, down to the minute. But we also would be acting, way out of our duty of practice if we were to encounter a patient who was very, very ill and required a high level of care, and we chose to see someone who had come 5 minutes before him solely on the basis that the person had been there for 5 minutes before him. And that was the point that I was trying to illustrate earlier with the heart attack or the stroke, that some things require immediate attention. And once we have sorted those patients out and we know, that there's a doctor assigned to them, that they are receiving some kind of treatment or intervention in between, then we also look at the times at which people have arrived. So it's not that at any means that we leave the time out, but we do have to take into account who is very seriously ill, right?
Right. Mm-hmm. Perfect. So, let's say you've been. Is there any other protocols or any other steps that happen after that? So you triage, and you decide, okay, now I'm going to be seen. What happens then?
Okay, so I'm gonna kind of paint the picture as best as I can for you. So you come to any, you can come via two routes, really, either in the ambulance, and the ambulance really should be reserved, everyone, for people who are severely ill. The reason for that is because if you think about it, if someone is at home again having a heart attack, or a stroke, or is so sick that they are going to need CPR, they will need to be in a vehicle, being transported by skilled personnel who can provide that CPR for them on the way to hospital. Whereas someone who is not as ill, can come via private transport or public transport, because they don't require that skill and supervision. All right, so we try not to encourage people to use the ambulance service indiscriminately. So you can come via either route, and then you arrive at the ED. So you're here now as an emergency. You actually sign your name up and you put the time that you have arrived. A record is generated for you by the medical records clerk. Then you go to see the triage nurse, and there she will ask you a few questions to find out what is wrong. And she will take your vital signs. If you are in pain, we will start your pain management at that stage. And any other medications that we think might be necessary at that stage, but that isn't necessarily a physician seeing you. That is just us starting your treatment in the emergency room. From there, you will wait until a room is available for a physician to see you. And again, this will just depend on the time of arrival and how severe your presentation was. And this, we can then start, since our focus of this discussion is on endometriosis, I think we can then start to talk about a few of the things that might bring the patient with endometriosis to the emergency room. So endometriosis actually is a condition where the endometrial, it derives its name from the kind of tissue that it is. So the most common places for that tissue to be are in the pelvis. So on the outside surfaces of the uterus and the fallopian tubes, in the ovaries, where it forms what we would call chocolate cysts. And again, in medicine, especially in pathology, they tend to use food to describe things. So the cysts actually, when they open them up, tend to look like chocolate with coagulated blood when they open them. And that was how they got the name. And I will talk about the chocolate cysts a bit later. Endometriosis can also cover the outside surfaces of the bladder and its inside surfaces, the outside surfaces of the bowel and its inside surfaces, anywhere within the pelvic cavity, and then further north, the abdominal cavity. Above that, your diaphragm is that muscle that separates your chest cavity from your abdominal cavity, and endometrial tissue can find itself there. It is more rare, but it can happen. And again, on the more rare side of things, you can have extrapelvic endometriosis or thoracic endometriosis, where you have endometrial deposits within the lungs or the lining surrounding the lungs. And that can be very dangerous as well, because you can have bleeding there when the patient is menstruating, and you will have blood around the lungs, which is called a hemothorax, or you can have a lung collapse, which is called a pneumothorax. And those are things that, we need our endometriosis patients to be aware of, because those are the things that we would want you to come to the emergency department with, should you experience them, right?
as I guess, for that will present with pain in the chest,
coughing up blood, shortness of breath,
okay.
right? Those things, and it happens very suddenly. Yeah. So, and you don't want to stay home and watch that. That is very abnormal, and you should just come to the emergency room because we have to treat it.
Yeah, and so I guess it's very important for, I think because endometriosis is so painful, it's important to kind of, I guess, know your pain and when it's off or when it's different, when it's changed, and when it's in a different place.
Yeah. Mm-hmm. And so back to knowing your pain, I'm so glad that you said that because one of the things that I encourage patients to do, and one of the things that I do, and I will talk about a bit later, is keeping a pain diary, because that can then, and keeping a pain diary is just something really simple. It means that you get a notebook or some pieces of paper, and you get the date and some columns, and you write what your pain level is like each day. You can choose to decide how many times a day that you want to document what your pain level is like. You can write what foods you ate that day, if you exercise, if you had to take medication for the pain, anything that you think may have actually affected it. If you were under stress, anything at all, if you were menstruating, and those kinds of things can help you to know your pain a lot better. And when you have those tools, those are things that you can walk to your doctor with to say, well, you know, when X and Y happened, the pain got worse. And then it can help the doctor to then maybe investigate something a little bit further for you. So, and it helps you then to notice things about your body more, because you are then always consciously writing about your pain. And so you think about what is happening to your body on a deeper level. And so then no one will know your pain. No one will ever know your pain better than you do. But you really, whenever you have any kind of illness, you have to be the expert at your body, right?
Speaking of that, and this might be a little controversial, because let's say you know that something is up, you know that, you know, this is not, and as you know, physicians often, obviously they know that women with endo have pain, and so you present to the emergency, as an emergency department, and you know that this pain is different. This pain is something, like, I'm not just here because, you know, this is my usual pain. This pain is, and even if you are, you're valid and that's a valid reason to be there. But you know that something is up. And how do you best get that point across to the persons attending you, so they understand kind of the severity of the situation? How do you advocate for yourself in that moment? Like, what's best to do?
I think exactly the way that you have said it there is the way that you should say it to your physician. As I said, if you have the benefit of keeping a pain diary, and you can even keep it on your phone so that it's always with you, and you can say, well, you know, for the past 3 weeks, doc, the pain has been at a 5. And today when I got up, it was at a 9. That is very abnormal for me. Then that doctor, you know, has to stop and has to say, well, this is abnormal for this patient. Yes, they have chronic pain, but they are able to cope with it at 5. And today is at 9. So I need to be the one to find out, why is it at 9 today? And you need to be very clear in your words. Sometimes I find that when I am in pain, or when patients are in pain in general, you are just in so much pain that you find it difficult to articulate for yourself.
Yeah.
So if there's someone close to you who knows you well, you can bring that person with you to help to tell the story or to help to advocate for you. That is one way as well.
I guess regardless of if you have the diary or not, or the numbers, I guess it's important to say, this is not my normal.
this is not my normal pain. Once you say that sentence,
yeah,
right, then we know that there's something wrong, right? That's something acute, meaning something happened today within the last couple minutes or hours, right? Something different has happened, not the normal chronic processes that we know are going to lead to your pain, right? So once you use that sentence, that this is not my normal pain, full stop, right? Another thing you can do to help you, and it may, you know, we would love, truthfully, the more information that you walk with on yourself is the more helpful your encounter with your doctor can be for you. So I discovered this website for women with pelvic pain called the painperceptionproject.com, and it allows you to fill out a free questionnaire about your pelvic pain, and you can walk with that to your doctor. So you can use that then as your baseline description of your pain. And then when you notice that anything deviates from that and you find yourself having to seek medical attention, you can then use that as your point of reference as well. And so I will type that up for the association and have it posted on their page as well, so that everyone can have access to that resource, because it's completely free and we like things that are free.
Yes, we do. So I'm actually going to be devil's advocate now.
Yeah, sure.
Let's say, you know, a no warrior presents and they say, okay, they have everything by the book. And even if they don't, but let's say they say, okay, Dr. Parris, my pain is not normal today. It's usually a 5. It's been a 5 for the past 3 weeks. Today woke up, it's a 9. And Dr. Parris, you know, is like, yeah, whatever. I know that's not what you'll be like, but Dr. Parris is dismissive, in my opinion. And, but I don't feel as though Dr. Parris understands. I don't think she gets that this pain is really, you know, cutting me up, eating me up. How do I get that point across to her, you know, that this is serious?
Well, firstly, I would suggest that you remain calm, number one, for yourself, because stressing yourself further will only make you feel the pain more. That is like scientifically proven, that when we feel more emotion, that our perception of pain, unfortunately, will be worse. So you remain calm. And then I think you owe it to yourself to have another discussion with the doctor, because especially in an emergency room, it is a very busy environment, and oftentimes the doctors are interrupted so many times. I wrote a paper on it, and the average emergency physician is interrupted every 7 to 9 minutes.
Okay.
And you know, if you think about that, if you were watching like a half an hour show, that means you would be interrupted like 3 to 5 times or more during that show. Especially if it's a senior physician, because the more senior you are, the more you're going to be interrupted by people seeking your counsel. So their minds are often running at a mile a minute, and it's not that they don't want to dedicate their attention to you or care about you. Maybe they actually didn't hear the entirety of what you were saying, and therefore didn't get that you were really in serious pain, because often patients with endometriosis is not going to show on your face. You know, you are good at masking pain, especially if you've had it for years. So you may not be crying and bawling, and you may just be sitting peacefully, but you know inside that your insides are, you know, feeling like they're being torn apart. So I would say, you know, I would have another discussion with that doctor. And if at the end of that discussion, where you've clearly said that, you know, doctor, my pain is a 10 on 10 on the scale, I feel absolutely awful. You know, this pain medication has not worked for me, or whatever the case may be, that whatever all the concerns are. And I always encourage people to write things down because you sometimes can forget. And you know, when things are written down, then that person also who you're having the discussion can see it written down as well. And then you have two ways of communication: the oral conversation that you're having, and then you have like this visual cue that tends to reinforce it. If at the end of that, so sometimes then at the end of that discussion, the doctor, any good physician I would imagine will say that they may not have realized, and they will then do X and Y and Z for you. It may be that they will change their treatment plan and include an extra investigation like a blood test or a pregnancy test or an ultrasound, or that they may try another round of medication or try a different medication for you. And you may feel safer and satisfied at the end of that discussion. The alternative to that response is that you may still feel like they are not getting where you are coming from, or they are not understanding the severity of your pain. And the truth is that you are in charge of your own body, and you are always entitled to having another doctor see you. You are always free to seek second opinion from another physician. There is nothing stopping you from doing that. No matter where you are in the world, no matter what time of the day it is, you are free to ask for someone else to see you in order to make sure that nothing is missed. In fact, in our emergency room, if someone presents, you know, let's say you came a week ago with abdominal pain, I saw you at that time for that complaint, and I am on shift today, and you return with abdominal pain, I am in our system, I will not be allowed to see you because we would want a pair of fresh eyes to see that patient. Just to make sure we're not accusing Dr. X of being a bad physician at all, but we are just doing our best to ensure that no alternate diagnosis is missed in that case. And the truth is that you just have to remember that we are all human first, no matter who you are on the side of the table. So sometimes somebody may not understand something depending on the way that you have said it, or if you are not a very vocal person, because some people are not. Some people are just very, you know, very peaceful and very quiet. The doctor may not have gotten or completely understood from you everything that you are trying to portray. So just call them aside and say that you have something else to say to them.
I know what I also take away from that, which is probably not what you want me to take away. But what I also took away from that is, you know what, y'all are going to be interrupted anyway. So I could well interrupt you and get my point across. Let me be one of those interruptions, and let me speak up for myself.
You will be interrupted.
Yeah.
It is a part and parcel of life in the emergency room. And as I said from the beginning, the nature of it is that at any given moment, there's an ambulance at the door, or someone has collapsed onto the floor, someone is having a seizure. So we are going to be interrupted. And that is also what people need to understand about coming to the emergency room, is that we can't predict when someone will have a seizure, but we need to attend to it, because leaving someone seizing without intervening for too long means that we are starving their brains of oxygen and leaving them irreparable brain damage. And no one would want that for their relatives. So the things that you would not want for yourself or your relative, we ask people to be understanding of when we have to divide our attention to go to someone else who needs it urgently in that moment. But it does not mean by any means that your pain or your treatment is less valid or less necessary. It just means that we have to kind of deal with the urgent situation to somewhat to you who might be stable.
Got you. Perfect. All right, so a little surprise for our viewers is that you, Dr. Parris, you are actually an Endo warrior. So tell us a little bit about that, and thank you for sharing that and being open to sharing that on this platform.
I think that my journey is similar to the unfortunate story of so many Endo warriors out there, in that the time to diagnosis was quite long. I would have, I mean, my story, I have polycystic ovaries as well. So that was picked up quite early when I was 16. So I knew about that for a very long time, but my periods were always painful and long and awful. And I kind of just thought that it was something that I had to live with, because culturally people just tell you that you have cramps and cramps are something to live with. And so I just continued to live with them. I they were so bad that I would, there were times when I had episodes where I fainted, and the pain was just so severe that I really was not functioning very well. I went to university and I had basins under my bed that were reserved for when I was menstruating, because those were what I was going to vomit in, because I could not make it to the bathroom to vomit. When I was 21, how you really make a diagnosis of endometriosis is that you have to take a look inside at the tissue itself. And I had a laparoscopy when I was 21 for an ovarian cyst, and they said they didn't find any endometriosis. And even though it had been considered at that point as a diagnosis because of all of the pain that I was experiencing. And by that point, it was really severe, and it was interfering with me being able to study in medical school properly. I still managed to do pretty okay, but it was very difficult. So I continued with the pain. Wondering if in the back of my head, if it had been missed, or if I was the one who was crazy. I had been to several doctors, and none of them could really quite find an explanation for it. Until finally I had another laparoscopy when the pain had become so unbearable that I could not, go to work without having dark eyes and bad feels like the old people, and I had to smell my alcohol to get through the day. And I, had to make the decision to have the neck surgery. And so that was when I found out, but by that time I was 28 years old. So it was a long journey. What I will say is that those experiences, though painful, they make you stronger. They make you more compassionate, because when you encounter others who go through painful things in life, you are less likely to judge them because you have walked in those kinds of shoes. So, sometimes you wish that you didn't, it is a disease that you wish you did not carry the burden of. But I have also had the pleasure of meeting, some really wonderful people. Some of them I just have met on the internet, just when, in my darkest hours, yes, I am a doctor, but I am a human, as I keep repeating to you all. We are all human first. I would have needed my own support, and sometimes people without chronic disorders or chronic painful disorders will not always understand what you are going through. And so I sometimes would just search on the internet for support groups, or on Instagram, there's just a really huge chronic illness community there, and you can just message someone and you will realize that there are a lot of just nice humans dwelling on the earth who share your pain with you and are willing to walk the walk with you, even if they are miles away, and it lightens the burden.
If you had to, let's say, give any advice, like your 3 top bits of advice for fellow Endo warriors, like what would that
be? I would say after, obviously the theme of this discussion, a lot of it had to do with pain and with coming to the emergency room or interfacing with doctors in general. But we have to interface with people in general. So sometimes you're going to face it in your workplace where people may not believe your pain, or may want to wonder why you are ill so often. Or, I mean, truthfully, it really has little to do with them and everything to do with you. But just know that you are not a weak person for having endometriosis or for having any other chronic illnesses. That you remain strong, and that there is no day when your pain is not valid. If you were in pain yesterday, it was valid then. If you are in pain today, it's valid now. And if you're in pain tomorrow, it is valid tomorrow. No matter what anybody says to you, even if they are wearing a white coat and they have 10 letters after their name. And I say that knowing the consequences of it. But your pain is valid, and you deserve to be treated as though it is valid, and never stop searching for good treatment and safe places for yourself. So that was long, but that was one. Number 2 is that chronic pain, again, can make people very depressed. So you have to find ways of keeping yourself afloat, keeping yourself positive. I personally find it reassuring and lovely that the color for endometriosis is yellow. So you don't have to tell everyone. Some people are, okay with other people knowing about their illness, but some are not. And you will make your own decisions. But you can have your own little yellow things that remind you that you are strong. Or you can have your own little affirmations, your own little journal. For me, I also have jewelry that reminds me that I am strong. There are things called mantra bands. Again, I am going to send that link to the association, where you can go and choose from any kind of slogan to a Bible verse, anything that just reminds you to keep going. So whenever I'm down, sometimes I will just look down at my wrist and I will be reminded that I am strong and that I deserve to keep going. I also think that we talked about having conversations with doctors or medical professionals in general, and not necessarily being understood all the time. And so I think it's a lot of people don't really walk with their medical records. And I think in 2020, it's time to change that. So however you choose to have your medical records with you is personal. And I think you should choose the option that is easiest for you. But find a way to have your records with you. They go a very long way in translating what is happening with you to the people who are treating you. So you need to monitor your periods with some kind of period app. There are a lot of them, and you can just choose one and download it on your phone and monitor your periods and monitor all of the things that you thought had changed or affected the pain or your flow or anything like that, so that you can bring it up to your doctor, because you will not remember everything, and endometriosis is associated with that lovely thing called brain fog, so it makes us quite forgetful, but it's okay. And or you can be old-fashioned like me and you can print the things on folders. So what I mean is that if you've had an ultrasound, that you have the ultrasound in a folder, nice and neat, clean, and you walk with that to your doctor's appointments. Right. I encourage you to always have a copy for yourself. Sometimes the doctor may take it from you and you may not get it back, but always make enough copies that even if they take it from you, you always have one for yourself. And if you do have someone who is close enough to you, be it a friend or a relative, you know, you can give some of that information to them as well, so that if you are ever found in a situation when you can't speak for yourself, that they can speak for you and they have this information available to them and therefore available to the doctor. That those things would be things that have helped me along the way, and things that I, as a physician, also advise my patients. I would like to see them do more.
Perfect. Well, thank you so much. That was informative. I mean, I learned a lot about, you know, emergency medicine. My perspective on it has changed, and my perspective on what goes on in the emergency room and triage and everything. I hope that really helps a lot of people to understand the process that occurs. I think you gave really invaluable information about, you know, knowing your pain, expressing your pain to your physician, and, you know, really advocating for yourself. Make sure you get your point across to them. And, you know, what you said at the end was perfect about remember that you are strong, and having the reminders to remind yourself. And as our slogan says, invisible does not mean imaginary. Thank you so much, Dr. Parris, for joining us on this episode of BAEP Talks. Thank you for all the information and for being so candid and open and sharing your story. We really appreciate it.
You are so welcome. And as I said, the resources that I did speak about, I will forward to the association through you. Because I saw that the web, and everybody needs to go to the website as well. That's one of the resources. The website has been updated. It looks very spacious, and it has lots of resources, doctors, counselors, you know, everybody, physiotherapy, everybody that you could need to in your armament, because you need almost a team to take care of you. They're there. And then sometimes, you know, you feel alone and isolated. There's stories there as well from other real women who have the same illnesses as you. So the association is another big resource available to you.
Thank you, Dr. Parris. And you be well. We'll connect again.
Thank you. Yes, we will. I'll be back.
Yes, for sure. Bye-bye.
All right, bye.